part of the global. Okay. So I'm going to be leading the discussion on reproductive health in women with sickle cell disease. And this is the outline that I intend to go through. It's going to be like an overview. I'm sure many of us are already doing so much caring for women who are living with, and children who are living with sickle cell disease. We'll have a brief overview of what sickle cell disease is, the global and regional prevalence, the justification for addressing reproductive health in women with sickle cell disease. And under that, we will talk about the menarche, their developments to cycle, a bit of sexual health, and then fertility and family planning in such patients. And when they do get pregnant, how we can be of better service, provide quality service to prevent morbidity and mortality in pregnancy during antenatal care, during the labor and delivery in the puerperal, and also in the postnatal period. Sickle cell disease is an autosomal recessive multi-system disorder because it's a systemic, because the pathology has systemic effect. We need to build a coalition of specialists who can best understand their needs and support their health, because the multi-system disorder is characterized by chronic hemolytic anemia, painful ischemic episodes of vaso-occlusion, and therefore from that progressive organ failure. Now, in sickle cell disease, hemoglobin molecules tend to polymerize due to their low solubility when there's low oxygen tension, especially in the peripheral capillaries and vascular bed, resulting in sickling of the red cells. Sickling of the red cells, then the cells lose their normal functioning of being able to carry oxygen to the organs, leading to chronic fatigue as well as to episodes of painful crisis. Sickle cell disease is the most common monogenic disease with millions affected worldwide. We do know that the vast majority of sickle cell disease births occur in sub-Saharan Africa, even though it does occur in globally, generally. Now, from the foregoing, we can see that sickle cell disease can be regarded as having public health significance because of the birth rate of 382 births per 100,000 live births, and about 8 million people living with sickle cell disease globally. And like I said, majority are in sub-Saharan Africa, where also the highest mortality burden of sickle cell disease manifests. Nigeria, unfortunately, is one of the 6 countries accounting for almost nearly half, about 44% of global incidence of sickle cell births globally.
No, it's recommended symptom.
Now, what is the justification for addressing reproductive health in women with sickle cell disease? Due to because early diagnosis and improved pediatric care, we can offer individuals with sickle cell disease better reproductive health performance and improve even the outcome for both the women and the newborn and their families in general. Females with sickle cell disease do have unique challenges as it relates to reproductive health and practices. And as per the global initiative of inclusiveness, not leaving anyone behind, taking care of every need of every peculiar group, we do need to have a focused care for patients or people who are living with sickle cell disease. Pregnancy in sickle cell disease patients can be of higher risk and often needs combined management and monitoring from both hematologists, obstetricians perspective, and even other professionals like social workers, like microbiologists, and so on and so forth. And therefore, where the care is aimed to be of a flagship care, we should develop a multidisciplinary team. And this is one of the reasons why this workshop is being conducted. And we do hope that at the end of it, those who are attending will find the need or the needers for forming such a team if it does not exist as of now. Now, considering the hypercoagulability in this population, there are specific recommendations related to contraceptive choices. One is that evidence suggests delayed onset of menarche. Most vaso-occlusive pain occurs with menstrual cycles, and so it actually shows that the menstrual cycle can be of more higher challenge than the general population. Neonates of women living with sickle cell disease require close monitoring for prematurity, neonatal abstinence syndrome, and hemolytic disease of the newborn. These are complications or challenges that have been known to be to occur more in patients with sickle cell disease. The chronic inflammation seen in sickle cell disease as a result of sickling, hypoxia, and so on, and infection may predispose women to preeclampsia in pregnancy, which may in turn limit fetal growth and increase the likelihood of preterm birth and other complications that arise or culminate from hypertensive disorders of pregnancy, both in the mother and also in the newborn. The complications of sickle cell disease are both acute and chronic, such that when women with sickle cell disease become pregnant, the normal physiological changes that occur are in a background of already affected organs, systemic organs, and also increased hemolysis, vascular damage, and inflammatory processes. As I said earlier, girls with sickle cell disease experience menarche about 2.5 years later than girls without sickle cell disease, primarily as a result of complications of anemia. In a study conducted by Drosin et al. In 2021, and this is in Nigeria, the mean age of menarche in Kaduna was found to be 15.6 years, when actually in the general population, mean age of menarche now is actually reducing and ranges from 10 to 12. Adolescents with sickle cell disease are more likely to have higher rates of dysmenorrhea than those with normal hemoglobin. And this is what the adolescents may face. Unfortunately, the adolescents that have more complications, which may include, for instance, reduced blood flow during their menstrual cycles, do also get alarmed that they are not losing as much blood as their colleagues are, and that's very unfortunate. So they will need to be reassured and counseled to understand why. Women with sickle cell disease are more likely to experience dyspareunia than other groups of women, and they are likely to experience sex orgasm-induced sickle cell crisis, which, unless the couple understand why, may actually disrupt family coherence, and so on and so forth. What about fertility in women with sickle cell disease? Girls and women with sickle cell disease face increased infertility risks, basically because the chronic anemia, the sickling pathology, and hemolytic episodes do show that the ovary may be affected, and in fact, the ovarian span may be reduced. As might be expected in a disease of accelerated aging, there is accelerated decline in ovarian reserve compared to unaffected individuals. So the period of fertility for patients who are living with sickle cell disease is compromised. And the same thing happens, therefore, with menopause. As menopause onset may be sooner because of the accelerated ovarian aging in women with sickle cell disease. Now we look at an overview general issues relating to pregnancy complications in women with sickle cell disease. One of the major challenges or complications are the hypertensive syndromes, preeclampsia, eclampsia, and due to endothelial dysfunction or damage, inflammation, or placental infarction in this sort of patient due to sequestration and hemolysis. Venothromboembolic phenomenon increases further in such pregnant women. We already know that in pregnancy, hypercoagulability occurs generally, physiologically. But in women who are living with sickle cell disease, this change is enhanced, and therefore veno-occlusion is more common in women living with sickle cell disease. Therefore, increased pain due to acute, chronic, or recurrent hemolysis or sequestration, acute chest syndrome, and acute exacerbation of anemia and splenic sequestration can occur. And all of these will eventually lead to dynamic changes within the systems and the organs. Worsening steady state of anemia may occur, and proteinuria may signify worsening renal disease. Hepatic dysfunction may also occur, and preterm labor is higher in patients with sickle cell disease than the general population. Therefore, delivering requiring more of cesarean section, which of course attracts higher risk because of the poor perfusion, low oxygen tension, and so on and so forth. What about maternal and perinatal mortality are therefore higher in patients with sickle cell disease if they do not have a focused and multi-system, multi-professional care that they deserve. Now, apart from pregnancy and childbirth, we should also have special consideration for women living with sickle cell disease regarding family planning. Because as we will see later, actually understanding these challenges and the risks that attend with pregnancy in sickle cell patients will help couples and individuals to determine their fertility, either by limiting it or by spacing it appropriately and preventing complications. Progestin-only contraceptives and sometimes combined hormone contraceptives are recommended in women with sickle cell disease due to their risk of thromboembolism, which is better in patients who are using progestin-only contraceptives. Progestin-only contraceptives are classified as category 1 by the Center for Disease Control and WHO, meaning that in patients with sickle cell disease, they do not have any restrictions on their use, provided it is an informed choice by the client. However, patients with sickle cell disease may use other contraceptive methods based on the recommendations of their provider and in keeping with counseling for choice, which is in any case applicable to all clients seeking contraception, whether they have sickle cell disease or not. Now, we started by talking about multidisciplinary care for these patients. Based on what we have said so far, we can now see that indeed a typical multidisciplinary team looking after such patients should include professionals that can minister to their needs, and this will include obstetricians, midwives, hematologists, anesthetists, and intensivists, those who look at patients in intensive care with expertise in pulmonology. And in fact, beyond this, you also may include social workers, for support and other areas of professional care that some of the patients may require, like physiotherapy, physical therapy, exercises. Multidisciplinary care impacts on the outcome for the mother and in reducing perinatal mortality. And I think this is what is global best practice, which our teams or our centers should adopt in caring for this patient. Unfortunately, these teams are being eroded or disintegrated by emigrations and people leaving and so on. As we know that many of the facilities now have challenges in recruiting new residents or even new consultants, because many just japa, because of the japa syndrome. The multidisciplinary care supports individuals and their families in clarifying values and preferences in making highly consequential treatment decisions, such as, like I said earlier, family planning practices, even delivery choices, and access or an uptake of care, even while as an adolescent and also before pregnancies. Okay. Now, antenatal care, what about the antenatal care? It should be particularly, that is, antenatal care in this patient should particularly focus on continued education to avoid crisis triggers. Crisis triggers that, triggers sequestration crisis, hemolytic crisis, such as dehydration from vomiting. Blood test and monitoring for asymptomatic urinary infections in pregnancy should be made routine, and patients should be screened all the time for pregnancy-induced hypertensive disorders, including preeclampsia, and this should be carried out on monthly basis, along with ultrasound scans to assess the fetal growth and liquor volume as an indicator for fetal assessment. Severe crises in pregnancy are most frequent, especially in the third trimester, and may precipitate prematurity. And this is one of the complications that affect the perinatal mortality in this category of patients. Therefore, antenatal management, of crisis should include keeping the woman warm. Patients should be counseled on hydration and on avoiding air crowding and areas of low. Adequate analgesia should be given when needed, and screening for and treatment of any infections should be make a priority. Thromboprophylaxis should be given to women admitted to hospital with acute painful crisis, because these are usually caused by sequestration and coagulability. And it is suggested that the influenza vaccine, if it had not been given, should be recommended, because all the influenza in pregnancy in this patient does make worse all the complications that we have talked about, whether for the mother or for the fetus. Now, during labor, all the preventive measures that have been instituted or put in place in the antenatal during antenatal care should continue intrapartum. And pregnant women with sickle cell disease who have a normally growing fetus should actually be offered elective birth through induction if they have not gone into labor after 38 weeks of pregnancy, or by elective cesarean section if this is indicated. And you recall that for the cesarean section for anesthesia, analgesia should be very regular in these patients to avoid pain and hypotensive. We should also, of course, prevent low oxygen perfusion during anesthesia. And so this patient, this is part of why the team, especially during labor, should include the team, the anesthetic team on duty in labor ward. Mode of delivery should be led by obstetric indications, should be very professional and technical. And spontaneous vaginal delivery is mostly often when there's complications that threaten life. Team, especially the midwife in charge, the senior obstetrician, the anesthetist that I mentioned, and hematologist should be informed as soon as labor is confirmed. The mother should be kept warm, well hydrated and oxygenated, and prolonged labor should be avoided, as this, leads again to sequestration crisis. Epidural anesthesia is the pain reliever of choice. We should try to avoid the use of pethidine for obvious reasons. Continuous intrapartum electronic fetal heart rate monitoring is also recommended, owing to the increased risk of fetal distress, which may necessitate operative delivery, and therefore increasing the risk of anesthetic complications. Routine antibiotic prophylaxis is currently not supported by any evidence, and therefore should be as much as possible avoided unless there's an indication for using antibiotics. Postpartum management of women with sickle cell disease will include avoiding the increased risk of postpartum hemorrhage, avoiding infections, and thromboembolic phenomenon. Therefore, maternal oxygen saturation should be maintained about 94%. And the patient should have adequate hydration based on fluid balance until discharge. No molecular weight heparin should be administered while in hospital and 7 days post-discharge following vaginal delivery, or at least at 6 weeks following cesarean section. Antithrombotic stockings are recommended in the period after delivery, whether it is by vaginal delivery or by cesarean section. At this point, I'd like to give a summary that women with sickle cell disease form a peculiarly at-risk group, and their reproductive health requires a team approach to deliver quality care for them, for inclusiveness, and in ensuring that no one is left behind in the minimum package of healthcare. We globally now, the practice is to have a team of professionals in any center where these patients are being looked after. And particular attention should be paid to the risks that they're exposed to, preventing them, and especially ensuring that they understand the basis for the care that is being recommended for them, and they understand the responsibility, the contribution, the part they have to play in ensuring high quality care. I will stop here, and if there are questions or clarification or comments, I will take it. These slides, I think, will be distributed in the package after the seminar, and you can find a lot of references which can help us clarify some things that we may have. Thank you for listening. Any comments or questions? Yeah.
Please, do we have any comments or questions? We would like to take questions.
Hello. Yeah, Professor Nodu.
Yes, sir. Good morning, sir, and good morning, everyone. It's just to say that it's been an absolute pleasure listening to you and learning some, fine details about the management of women in sickle cell. Thank you so much, sir.
Thank you
for the wealth of experience. Thank you, sir.
Thank you. Any other comments or questions? I think people, those who want to ask questions or pass comments, should unmute and lift up their hands so that we can identify them.
Good morning, Prof. This is
Good morning.
From Ile-Ife speaking. Thank you for your
okay.
talk.
Good morning.
Yes, sir. Yes, thank you very much. We learn every day, and it's nice to have these sort of webinars to bring us up to date as to what is going on in our areas of expertise. You mentioned that if a patient who is pregnant and who has sickle cell disease has vaso-occlusive crisis, then you should use anti-thrombotic agents. Now, what sort of level of evidence do we have to support that? Have they done clinical trials to say that we should do that? And at what stage of pregnancy? And what's the choice of anti-thrombotic agent that you use? Thank you.
Thank you. Of course, as we all know, vaso-occlusive disorder complications and pregnancy by itself is an hypercoagulability state, whether in patient with sickle cell disease or not. But so the question is, if a patient with sickle cell disease now actually goes on to develop that complication, then that increases the morbidity and mortality for both for the woman and for the fetus or the newborn, whichever it is. And therefore, there is evidence to show that they require to reduce that risk, which was already there and being heightened by complications in labor, by using antithrombotic agents. You will also remember that I did say that after delivery, in fact, routinely, we are supposed to use stockings, we are supposed to administer antithrombolytic agent in a measured manner, and of course by monitoring the patient so that we also do not go overboard. Does that answer your question, please?
Well, not completely. I was wondering that, what level of evidence do we have? Yes, we know that these are the risks that could, cause mortality, morbidity in these patients. But what level of risk in terms of evidence do we have? Is it now a routine thing to do this, or it is for high-risk pregnancies, and then what's the choice of anticoagulant you're going to use, and for what stage of pregnancy? And it is standard practice that after surgery, that is, if there's a CS, we must give antithrombotic agents, okay, for a particular period of time. That is understood, yes. But without surgical intervention, so what level of evidence do we have? Do we have clinical trials that have said that we must make it a routine thing? That's my question. Thank you.
Yeah. The best evidence will be from clinical trial, but you know that, for such an issue where the non-intervention risk is very high, then doing a clinical trial has its own limitations because of medical legal issues that may occur. But I agree with you that clinical trials will be the best. However, observational reports have shown that if you do not, the risks, the mortality and morbidity is higher. So the evidence, the level of evidence may not be the best, but at least is the practice. Empirical information shows that the practice will improve the outcome for the woman and the fetus.
Okay, thank you very much.
Thank you.
All right, thank you, everyone. If there are no more further comments or questions, we would like to hand over to our Ghana team for the next presentation. Oh, Professor Inodu?
Yeah. So with respect to Professor Akiola's question. Yes, I would imagine that since this is sub-Saharan Africa is where you have the most numbers of sickle cell, likely to get pregnant and all of that. And if we need that evidence, it has to be here that we will generate such. But when you talk about evidence, the opinion of experts like Professor Jembede, who have practiced in this place, matters a lot if you don't have RCTs. Yeah. So that's just what maybe it's an area that we can look into. It would be very high risk trial to do, and I don't know who will fund that, but we can look at that. Thank you. Over.
Thank you.
And the young ones can do a systematic review on this and see. Thank you.
All right, thank you, everyone. We appreciate you for joining us in this session. We would now hand over to the team in Ghana. Dr. Sandra Owusu, if you are ready, you might start your presentation now. Thank you.
So, Prof, there are some questions for you on the chat. Thank you. Over.
Oh, okay.
Good morning. Thank you for having us. Sorry, we are unable to share my slides. If you can allow us.
Okay, Dr. Sandra, can you just hold on 1 minute? Professor Jengbede wants to respond to a comment in the chat box.
Yes, so the question is, it's about sickle cell disease and blood transfusion as a result of PPH. Actually, some will say, why should the patient who are at risk of hypercoagulability develop postpartum hemorrhage? And the truth is that some of them, because of the low perfusion of oxygen, the uterus is not able to, have to contract and control postpartum bleeding after placenta separation, and so may actually suffer postpartum hemorrhage. But apart from the fact that the volume, even where the volume of blood loss is not beyond the globally accepted 500 mils, because these are patients who are already chronically anemic. And if losing 300 mils may actually have more effect on such a patient than a normal patient that loses 500 mils. So this is why there's also a need for that to happen. If she loses 200 mils at delivery, are we only to replace with 200 mils? No, the patients, I think we have to look at the clinical of 20 or 22 in a patient with sickle cell disease, you don't get so alarmed as to now rush to over-transfuse the patient, or even unnecessarily transfuse the patient. So the clinical state of the patient, the amount of blood loss, and your findings will help to determine how much blood you should give, if you should even give at all. Thank you. Sandra, please, over to you.
Over to you, Dr. Sandra.
Good morning, everyone. Thank you for having me. And I also want to say thank you to the leadership of the faculty for allowing me the opportunity to discuss chronic pulmonary complications in sickle cell anemia. So I'll discuss the epidemiology and mechanisms involved in the pathophysiology of sickle cell disease. And I'll also talk about some specific pulmonary manifestations, discuss steps to improve knowledge and the gaps in sickle cell pulmonary disease. And then we'll look at some lung function reports in children with sickle cell in Africa. And so I hope that by the end of the presentation, we'll all be able to enumerate common long-term complications in sickle cell anemia, discuss a basic approach to management depending on the type of long-term complication. And we'll also be able to highlight the gaps in research on long-term respiratory disease in sickle cell and some future directions. Sickle cell anemia or sickle cell disease is a severe genetic disorder with worldwide distribution. Know that the greater burden of disease is in sub-Saharan Africa, and there are 300,000 infants that are born annually who predominantly have hemoglobin SS genotype. In our population in Ghana, from previous studies, we know that 2% of infants born in Ghana are affected with sickle cell disease annually. So in terms of pathophysiology, we know when red blood cells flow through the microvascular environment, soluble in the deoxygenated environment and therefore becomes polymerized. Red cell membrane therefore becomes distorted, rigid, and has poor deformability. And once this happens, there are a cascade of events, including activation of transport channels, action of red cell membrane, and oxidative damage, which occurs heme that is released in plasma. Predominantly, vaso-occlusion occurs in the microvascular environment from entrapment of erythrocytes and leukocytes. Once polymerization of the hemoglobin molecule has occurred, vascular obstruction, ischemia, and a series of inflammatory events occur in this background of vaso-occlusion and hemolysis. It's important to highlight that interaction of erythrocytes with the vascular endothelial wall causes ischemia, obstruction, and then there's a cycle of restoration of blood flow, ischemia again, obstruction, which contributes to what we now see as reperfusion injury and which drives tissue damage. Oxidative stress also happens from overexpression of vascular adhesion molecules. And all this happens in the background of a lot of inflammatory processes, including cytokine synthesis and signal leukotrienes. Hemolysis does contribute to vaso-occlusion. Free heme in plasma produces free radicals, and these free radicals helps adenase 1 to move adenine into ornithine instead of adenine being converted to nitric oxide. Now, nitric oxide is a very important chemical at the vascular level because it regulates vasodilator tone, inhibits platelets and hemostatic activation, and sort of reduces the risk of hypercoagulability. So in the background of hemolysis and vaso-occlusion, nitric oxide depletion is a major factor, and as we'll see later, it contributes to the development of pulmonary hypertension. So pulmonary diseases in sickle cell anemia would come in the background of what we know as multi-organ involvement in sickle cell disease. Generally, people affected with sickle cell anemia or sickle cell disease would suffer from multi-organ involvement, where predominantly highly vascularized organs such as the brain, the kidney, and the lungs tend to be affected more. Chronic pulmonary conditions that we know in sickle cell anemia affects, as I'm showing, the vascular bundle. So bronchioles, that's the very small airways, the vessels, and the interstitium, or in a sense, the line parenchyma, all suffer. So you would see that in pulmonary disease, there's a lot of heterogeneity. Pulmonary disease in sickle cell begins early in childhood and is often progressive. And presence of respiratory disease in sickle cell anemia has been documented to contribute to morbidity and mortality, up to about 40%, especially in adults. So what is the spectrum of long-term lung disease? I must highlight that the acute complications have been discussed in a previous meeting, so I won't focus on acute complications, but we know that acute chest syndrome is a very important acute complication. So in terms of the long-term respiratory diseases, which are very heterogeneous, it affects the airways. It also affects the vessels, It affects both upper and lower airways, and there's vasculopathy. So we see that in sickle cell disease, you would have airway diseases that manifest as lung function abnormalities. Additionally, you would have airway diseases such as asthma and hyperactive airways. You may have vasculopathy, including pulmonary hypertension. You may have upper airway disorders involved in sleep, called sleep disordered breathing, and reduced exercise capacity. So airway abnormalities are common. They worsen with increasing age. It is important to highlight that from a lot of consensus papers, both the American Thoracic Society and the European Respiratory Society encourage that if we're performing lung function measurements for patients with sickle cell, in order to enhance comparability and discussion of results, it will be better to use what we call the Global Lung Function Initiative reference equations, at least 2012 equations. But now I know there are other modifications that have come up. And that interpretation of pulmonary function assessment must be based on the lower limit of normal. And abnormality of lung function must be set at the 5th percentile or minus 1.64 Z-score. So what lung function measurements can be used? Basically, for the airways, we need dynamic assessment. And plethysmography is what I would say the preferred, but it's more expensive, and I know it's not available, at least in any parts of Sub-Saharan Africa. So we tend to use spirometry, which also measures dynamic airway measurement. Plethysmography, in addition, the advantage of measuring static volumes. So plethysmography can give you your total lung capacity, which spirometry cannot give you. And it can also give you your residual volume, which spirometry cannot give you. So that's the added advantage. When we perform spirometry, it measures flow, and it will give us values like forced expiratory volume in the first second, that's FEV1, or forced vital capacity. Spirometry measurements can help us determine that patient has a normal lung function, obstructive lung function, restrictive, which also represents small airways, and in long-standing conditions, fibrotic lungs, and mixed airways diseases. So usually, when you perform spirometry or you request spirometry for a patient with sickle cell anemia, you would receive a result that would tell you that your patient has restrictive abnormality, which signifies small lung volumes. And in long-standing restrictive abnormality, you have small lungs or fibrotic lungs. Then you would have an obstructive picture, which signifies that there's respiratory airflow limitation. Within the spectrum of obstructive airway diseases, asthma is the one we know commonly, but there are other obstructive airway diseases that can exist in children with sickle cell anemia. So asthma is predominant, and we may even find children with hyperactive airways. In some cases, you may have patients with both restrictive and obstructive airways diseases. So how do we interpret spirometry when it's performed? Basically, we look at first your forced expiratory volume in the first second and your forced vital capacity in a ratio. If your ratio is normal, then you look at your forced vital capacity. If your forced vital capacity is also normal, then most likely your patient has a normal lung function. On the other hand, if you have a normal ratio and a low forced vital capacity, then you need to measure total lung capacity. But that is where the problem is, because in Africa, we are mostly unable to do that. So we base our measurements on only spirometry. So that will be a limitation. But from forced vital capacity measurements, we can derive restrictive lung disease, and sometimes maybe non-specific, where you need further investigations. if your ratio of FEV1 and FVC are low, then you would look at your forced vital capacity and decide whether that is normal. If you have a low ratio and a normal forced vital capacity, then spirometry, because at least it can tell us about obstructive airway diseases and to a minimal extent, restrictive airway abnormalities. So the screening tools that are available, ideally in many parts of Africa, we're supposed to be using spirometry often, but I know it's not readily available in all centers, maybe only tertiary and regional centers. But we need to understand also the limitation that even for spirometry, it's only performed at 6 years. So in the first 5 years, it seems like in many parts of Africa, we don't have a big hold on airway abnormalities and when it occurs and what mechanisms promote it and how we can prevent it. However, when we draw information from in high-income countries, it appears that starting hydroxyurea early in sickle cell may contribute to halting the progression of airway abnormalities in sickle cell disease. And how do a clinician seeing a patient in a sickle cell clinic determine that this patient must go for spirometry? We would look at some recommendations from the American Thoracic Society. Now, we know that when lung function is performed, basically, we see what is obstructive physiology or airflow limitation, respiratory airflow limitation. And the suggestion is that in sickle cell anemia, this is contributed by compression of small airways by congested peripheral vessels. When does it occur? What mechanisms? This is a major area that needs to be studied. But from high-income countries, we know that raised capillary blood volume seems to go in tandem with airflow limitation. And then for children that have small lung volumes or restrictive lung disease, they tend to have loss of lung volume when high resonance CT scans are performed. Maybe some of those patients have pulmonary fibrosis. That's also something that we need to begin to investigate to see how early does it occur and what can be done to halt its progression. Basically, lung function abnormalities, when they are present, begin to signify that your patient with sickle cell disease has chronic lung disease. So when we are screening, we know that it's important, for instance, when you receive your spirometry report, to look at your FEV1 values, because a persistently low FEV1 value has been associated with higher risk of death in adulthood. Spirometry, the recommendation is that at least from age 6 years, it will be helpful to perform spirometry for your patient, but maybe once a year, if it is available in your center. And that sometimes other additions, for instance, if your patient has restrictive abnormality on spirometry, then in your real world sense, you would need total lung capacity, which we don't have. But in some cases, a chest CT may also be important. These patients, do they need to see a pulmonologist? Maybe the answer is yes, but I am saying this knowing that there's very limited number of pulmonologists in Africa. But this is an area that is emerging as we begin to see our patients grow into the first decade, the second decade, and even into the 6th decade. We may need some pulmonology input. So let's look at some studies. So although I've attributed a lot of the work to high-income countries, I must also say that even in Africa, although limited, there are some studies that have been performed on children with sickle cell using lung function assessment. So this paper, I think, is about the latest in Africa now by a group in Makerere University at the Lung Institute, who looked at prevalence, patterns, and factors associated with abnormal lung function in children with sickle cell disease. So this was a cross-sectional study that looked at children 6 to 18 years. They did spirometry measurements in 332 participants, and one of their major findings is that up to 37% of their participants had abnormal lung function. Now, when you break abnormal lung function down, predominantly their participants had restrictive lung disease, which signifies small lungs. Then they had also obstructive and mixed abnormalities. Now, they predict that raised LDH, which signifies hemolysis, wasting, history of acute chest syndrome, and exposure to smoke from cooking has some relation to developing abnormal lung volumes. This was a study that I carried out in sickle cell disease children in South Africa. I must highlight that this was a small population. In total, we had 25 patients, but only 19 performed spirometry with a mean age of 10 years. But in this small cohort, we also realized that predominantly, nearly half had abnormal lung function measurements, and it was restrictive or small lung diseases. In this very small group, none of the participants had obstructive (6 to 18). Okay, looking at children 6 to 18 years, and they performed spirometry measurements. The major challenge also that they saw in this age group of children, both cases and controls, was that predominantly there was restrictive abnormality in the group. So the other study also, which came from Nigeria, Bankole Kuti and Professor Adimola, also looked at children 6 to 16 years and also compared them to controls. They performed spirometry. However, their interpretation was based on percent predicted values. And in this study, they also found predominantly restrictive lung disease, which shows abnormal lung function. And I can go on and on. So, although limited, the few studies that have been conducted in Africa seem to suggest that children with sickle cell anemia, their predominant airway abnormality is small lung volumes. What we don't know is, when does this occur? What mechanisms contribute to small lung volumes? Can we change the trajectory of these children? As I've highlighted, if these values tend to be low persistently in the 4th decade of life, there's a risk of a higher mortality in this age group. Now let's look at some studies from high-income countries. So in high-income countries, as I've highlighted, they have the opportunity to use more exuberant forms of lung function measurement. So they use spirometry, they use plethysmography, and they are able to tell a lot, especially in the younger age group. So, for instance, this group, this study by Alan Lant and his group highlighted the heterogeneity of respiratory disease in children with sickle cell anemia. They looked at both children and adults, and they performed oscillometry, which is non-stress, just your tidal breathing in children. And this can give you more information on the younger age. That is where in Africa, I want to highlight that that's a major gap. We don't have a lot of information in preschool children with sickle cell disease, what kind of airway abnormalities they have. Then they did plethysmography, and then they did diffusion studies. They also did some lung function laboratory measurements. And basically, they now put their participants into 3 categories. Category 1 had higher pulmonary capillary blood volume. Category 2, they had reduced diffusion capacity. And category 3, they had very high LDH. Now, what does this translate to? So having raised pulmonary capillary blood volume, they noticed capacity. They also realized that these patients had restriction and they were more of small lung volume. But this cohort was much older. And then the third cohort that had raised LDH had more hemolysis, as we know. And then they tended to have raised respiratory system resistance using oscillometry. Tells us that your patients will have peripheral or small airways disease. Then restrictive lung disease, when you see more of diffusion impairment. And then for the patients that had raised LDH, they were the patients that likely had asthma in the setting of sickle cell disease. Then there's another previous study by Cohen and colleagues also in the United Kingdom, which also highlighted performing spirometry and plethysmography in 104 participants. And they found that 30% had abnormal lung function, but predominantly obstructive airways disease rather than restrictive, what we see in Africa. So the discussion is that from Cohen's paper, which is a bit over 10 years, so maybe more dated, that there's no association between, for instance, having episodes of acute chest syndrome and having abnormal lung function. But let's remember this was a small population. Obstruction is the predominant airway abnormality, which they saw, which has also been reported even previously by, for instance, Arteta and colleagues, McLean and colleagues as well. So the variance is that we see more of small lung volumes in African children with sickle cell disease, and we see more of obstructive airways disease. But the limitation in Africa is that we don't start our lung function measurements early. We don't have information on preschoolers, but in high-income countries, there's availability. Now, I know there's also a lot of information. Sickle cell patients have more asthma, but is that the reality or is it just what we think? There are reports, multiple reports that suggest that in Africa, there's a higher prevalence, generally in sickle cell disease, there's a higher prevalence of asthma than the general population. And these are reports from high-income countries. So asthma is common, especially if the children have other allergies. Syndrome episode may be predisposed to developing asthma. Episodes of ischemia and reperfusion injury and even inflammation, as I highlighted in the pathophysiology, may be triggers. But then we also need to understand that this type of inflammation may not be the same type of inflammation necessarily as we know it from asthma patients who do not have sickle cell disease. So there is recurrent wheeze in children with sickle cell disease. This may or may not be asthma. If you find a child who has recurrent wheeze in the setting of sickle cell disease, look for wheezing associated with exercise, a parent diagnosed with asthma, wheezing causing shortness of breath, and go a step further to demonstrate reversibility. If these are positive, then your patient with sickle cell disease truly has asthma and needs intervention. So recurrent wheeze may not be asthma, or it may be asthma in the setting of sickle cell disease. It is also helpful, for instance, to review eosinophil count, immunoglobulin E levels, and if available, fraction of exhaled nitric oxide, and even spirometry. If your patient with sickle cell has asthma, they need inhaled corticosteroids because it improves the outcome. But this is in addition to also treating your sickle cell with whatever your national guidelines recommend. We need to pay attention to inhaler techniques, and we need to address comorbidities, including allergic rhinitis. I want to also share another study that we did in our center in Ghana here, involving our participants with sickle cell disease and lung function reports. We looked at the children 6 to 16 years. Basically, we looked at a total of 230 participants. We performed spirometry, and we recorded FEV1, FVC values. And for our cohort, in this case control study, we found more of all the participants with sickle cell in terms of anthropometry. The controls had better BMI measurements, Z-scores, weight, height, which we expect. It's of note important to say that a lot of our participants were already on hydroxyurea, which is a plus for us. Now, in terms of lung function measurements, comparing the cases to controls, our population also had more of small lung volumes, as has been reported in other areas in Africa. And they had worse lung functions compared to the controls. And we did not see much of obstructive airway disease or even asthma in our population. What were the factors that predict abnormal lung function, especially the restrictive lung disease? We realized that age and BMI. So if you have a low BMI, then your risk of restrictive lung disease was high. If you have a high BMI, then you are not likely to have restrictive lung disease. Our conclusion was that we have more of restrictive lung disease, which is the most common abnormality, has been reported, and there's a significant relationship between age and pulmonary function abnormality. But I must highlight that most of these studies that are coming from Africa have been reported from tertiary centers. It is possible that these are patients who already have very severe disease course, but why they develop the lung disease is what we don't know. So what do we need to do in terms of assessing airway measurements in children with sickle cell disease? It is time for Africa to generate our own data, using different lung function assessments. So in this review, we discussed that it may be helpful to introduce capacity, or even in the more exuberant form, if it is available, lung clearance index, which also gives us information about ventilation and ventilation homogeneity. This is important because we may be able to change the trajectory of lung function airway abnormalities in terms of care and its progression, because it has a direct effect on mortality later in life. Now, what are the other long-term abnormalities, airway abnormalities in patients with sickle cell? So sleep disordered breathing is also a major thing, especially in childhood, and that in people of African ancestry, up to 40% of them may have sleep disordered breathing if you use apnea-hypopnea index of greater than 1. So what is obstructive sleep apnea? Patients with obstructive sleep apnea have upper airway obstruction in sleep because there's increased collapsibility of the upper airways. Now, these patients would have snoring, daytime sleepiness, morning headaches, unexplained hyperactivity, and enuresis, which continues after school age. They have sleep fragmentation, so they have interrupted sleep. They may even have noted apneas. Children with these symptoms need to be evaluated. So in our clinics, it's important that we have high index of suspicion, we must have some form of screening tool for children that may potentially have obstructive sleep apnea. Now, they also tend to have sustained daytime hypoxemia. So this is something we can do in almost every center in Africa by just performing a pulse oximetry assessment as we see our patients in the clinic. What obstructive sleep apnea does is that it reduces gas exchange through ventilation perfusion mismatch. Patients tend to develop abnormalities in the pulmonary and lung parenchyma. And reduced gas exchange is a major thing because once ventilation perfusion mismatch occurs, then hypoxemia becomes persistent. Now, at the molecular level, we know that the oxygen dissociation curve, when in the low oxygen tension, triggers polymerization and many other events, and repeat cycles of hypoxemia and reoxygenation worsen sleep disturbances as it enhances oxidative stress and pro-inflammation. And this can contribute to both acute and chronic complication. Patients with obstructive sleep apnea have a high risk for intracranial arteriopathy and CNS events. And if you, in addition, find them with low daytime SpO2 measurements, then their risk for stroke is also high. So this is important that at the minimum, we need to screen our patients coming to the clinic, asking them about anything that could suggest obstructive sleep apnea. And in addition, we need to check oxygen saturation at rest during the day. Polysomnography is the recommended, but this is a very expensive setup, and it's also not readily available in many centers. However, the British Thoracic Society recommends a more simplified way of assessing oxygen saturation measurements at night, which is the preferred way of diagnosing obstructive sleep apnea, called overnight oximetry. Most patients with sleep-disordered breathing or obstructive sleep apnea may initially be managed conservatively with intranasal steroids and Montelukast. However, if you perform overnight oximetry and these patients have worse scores, so frequent desaturations going into the 60s and 70s during significant sleep time, then these patients need intervention. So one intervention may be adenotonsillectomy, depending on the age, and this will be decided by your ENT surgeon. The good thing with overnight oximetry is that it helps the surgeons to determine who should be managed conservatively and who should go for surgery as soon as possible. In severe forms of obstructive sleep apnea, you need continuous positive airway pressure. And some patients may even need home oxygen, but this needs to be determined on a patient-by-patient basis. The fourth complication, which is also important, is pulmonary hypertension. So pulmonary hypertension in sickle cell is also a known risk factor for early mortality in adults. And symptoms of pulmonary hypertension may be non-specific. You may have fatigue, dyspnea, on exertion. So these are questions we can ask our patients when they come to our clinic. Chest pain, unexplained fainting episodes, and most importantly, desaturation on exertion. If you examine the patient, they may already have signs of right heart failure, but this is a late, so we don't need to wait for right heart failure to occur because at that time it becomes difficult to intervene. So the screening tools, asking about fatigue, dyspnea on exertion, chest pain, is important. And one easy way that we can determine who to screen is to perform the 6-minute walk test. So the ultimate diagnosis of pulmonary hypertension in the setting of sickle cell disease is to use a transthoracic echocardiography. This is important because it would help. Otherwise, right heart catheterization, and I'm saying this knowing that I'm speaking in Africa, it's difficult. We don't have this in many centers. However, if you are able to document a mean pulmonary arterial pressure of greater than 20 millimeters mercury, then we know that the patient has pulmonary hypertension, and they may even have right atrial enlargement. So you need your cardiologist input as well. The pathophysiology of pulmonary hypertension is multifactorial. Some of it may even come from long-standing obstructive sleep apnea, which is not actioned. And then vasculopathy and chronic hemolysis. Nitric oxide, as we mentioned, very important. And so with repeated episodes of hemolysis where adenine is not converted to nitric, then you have depletion of nitric oxide. It can contribute to raised pulmonary hypertension. Chronic hypoxia itself is also a risk factor. Have a high index of suspicion. Any patient that complains of chronic fatigue, breathlessness on exertion, you can use the 6 minutes to 18 years. They need to have some screening. So ask about dyspnea on exertion. Perform your 6 minutes walk test because it can unmask patients who may have normal saturation at rest, but with activity, they quickly desaturate. Then you can refer them for echocardiography. Pulmonary hypertension in the setting of sickle cell disease is still an evolving area. However, there are studies to support that hydroxyurea is helpful. Supplemental oxygen is needed for those who are hypoxic at rest with oxygen saturation less than 90. You need to also look for comorbidity. So as I highlighted, pulmonary hypertension may be happening in the background of obstructive sleep apnea or even severe forms of asthma. So once you treat this, you may succeed in improving the outcome. The last thing to say is that generally we see sickle cell patients may have reduced exercise capacity. And this may be contributed to by the chronic anemia, by restrictive lung disease. So patients who have reduced exercise capacity may benefit from spirometry measurement. Obstructive sleep apnea and pulmonary hypertension would all predispose your patient to developing reduced exercise capacity. So what do we do in terms of lung research and sickle cell anemia? All the studies that I've highlighted in Africa, none of them was longitudinal. And this is one area that we need to quickly come in. We need large-scale studies. We need multi-center studies. We need longitudinal studies to help us better understand mechanisms of respiratory disease
Okay.
for the interruption. I was just summarizing with my last slide. We need long-term and large-scale studies that would help us better understand mechanisms of pulmonary disease. We need to manage sickle cell. Okay, so I'll be happy to take questions if there are any, and comments as well. Okay, so yes, the lung changes may progress slowly, but as I highlighted, especially for spirometry measurements, we know that low FEV1 measurements, which is persistent from childhood, tends to increase the risk of early mortality in adulthood. So it does impact quality of life, although it may be slow. And I must say that for some patients, it may also progress quite rapidly. What is difficult is that there are so many respiratory abnormalities. So we need to have a holistic approach to measuring, looking for what abnormalities would occur at what age. And most importantly, as I highlight, we need a lot of information on the preschoolers, because that is where our answer may be. That is where we may begin to change the trajectory of respiratory abnormalities. Thank you. Chronic sickle cell lung syndrome. Okay, all right. So basically, I will put it in the more background of chronic lung disease in sickle cell, and to say that there are multiple factors that contribute to it. For one patient, it may affect the airways. For another patient, it may affect the vessel to pulmonary vasculature. We tend to find them, especially in adolescents, already with chronic lung disease in a setting of sickle cell. Some come with low lung volumes. We don't know what contributes to it. But the experience is that for some patients, they progress rapidly, and by the second decade, we are already losing them. For some patients, too, that we find with abnormal lung function or even pulmonary hypertension, they do well if we are able to institute some of the lung protective measures, as in giving home oxygen and frequent monitoring, also ensuring that they are on hydroxyurea therapy. I think they tend to improve, but I mean, I'm saying this in the sense of expert opinion. We need large-scale studies. We need probably trials to be able to holistically answer this question. Thank you. Okay, kindly unmute and please go ahead and ask your question.
Good morning, everyone. Thank you very much, Dr. Mosu, for the very wonderful presentation. It was very lucid and easy to follow. So my name is Dr. Amarachi Obase. I'm a pediatrician from the Ibadan site. I'm joining from the Ibadan site. So my question is relating to patients with sickle cell disease. From your presentation and from literature, we know that there is some risk, some chances of having higher allergies. But I want to know, relating to things like the chronic hypoxic episodes that they have, is there any other pathophysiology that has been ascribed to why they are at risk to having allergic lung diseases? Then I don't know whether I heard clearly from the study that was done in Kumasi that low BMI was related to restrictive lung disease. That's for clarification. Then during your presentation, you suggested that different lung studies should be used. If you could please elaborate more.
Thank you. I hope I'm being heard. So I'll start from the last question. So in terms of lung function measurements, airway abnormalities, which are more common, in Africa, we basically use spirometry, which is good, but it's not the ultimate. Spirometry can only be reliably performed at the earliest 6 years of age. But then from the time your patient is born with sickle cell up and to school age, being what it is, and we know from high-income countries that a lot is reported on respiratory disease. So my suggestion was that, can we maybe institute other lung function measures like oscillometry? If oscillometry is available in tertiary centers, we may be quickly able to refer patients. And then also for those who are slightly older, we can use measures of diffusion capacity and lung clearance index, which tells us about ventilation in homogeneity. Because you see that the pathophysiology affects both the airways and the vessels. So we need to have some information across board, not only airways. We need holistic information. So that was what I was suggesting. Now, are there other mechanisms that contribute to inflammation, to asthma? Yes. So there is not only the Th2 type of inflammation that we know that contributes to asthma, which is the eosinophilic inflammation. There's actually neutrophilic inflammation through a Th1 pathway. And then there's also non-eosinophilic, non-neutrophilic pathway. So there are many things that are happening at the molecular level, which we probably don't have information on. And I think now there are a lot of papers that are coming up on inflammatory pathways in sickle cell disease, where we can also tap in, because that is where our answer may be. You know, now in the world of asthma, in the non-affected sickle cell patient, I mean, general population asthma, a lot of information has moved biological. Some of the biological agents that are being used, we could tap into it, and it may help the cause in terms of managing our patients. So that is what I'm suggesting. We quickly need to have big data. We need big data for multiple centers, because that's where we can influence influence treatment and maybe halt disease progression. I hope I've answered your question. I know there was a third one. If you could highlight the third one again, I can try and answer it.
Yes, please. I wanted to know from the Kumasi study, that was a clarification, the relationship, whether you say that low BMI was related to restrictive lung disease. Then just an additional, this is new. I want to know, does what is it called? Incentive spirometry, has it been shown to be effective in reducing the morbidity and prevalence of chronic lung disease in sickle cell disease patients? And do you have any studies relating to that? Thank you.
Thank you. Yeah, so from the Kumasi study, we found that having a low BMI predispose you to having low lung volume. So the reverse is true. If you have higher BMI, then you are likely not to have small lung volumes. And it's not only the Kumasi study, there's also papers from Ili Ife in Nigeria with the Kutis group that also showed something similar. In terms of incentive spirometry, I don't have data on incentive spirometry, but incentive spirometry tends to be more used for acute illnesses. So I'm not able to speak to the fact that it can, in the long term, change the trajectory in terms of developing chronic lung disease. But its use in the acute phase, I think for the few patients that I know have used, it does reduce morbidity, maybe shorten the length of hospital stay. But I don't have any large-scale study in that area. Thank you. So thank you very much. I don't see any more questions in the chat box, and I don't see any hands raised. So I will thank the organizers once again for giving me this opportunity to discuss lung disease in children with sickle cell anemia. Thank you, and over.
Thank you very much. Dr. Owusu, thank you very much. Over to you, Ibadan. Thank you.
All right, thank you, everyone. We'll be proceeding on a tea break for 30 minutes. We'll reconvene by 11:30 with a presentation from Dr. Marvin from University of Abuja. So we can proceed on the break now. Thank you.